Chapter 9 Test Paper 5. Questions. Time, 3 hours. 1 an 18-year-old girl with chronic cough and recurrent chest infections shows symmetrical upper lobe predominant varicoid and cystic bronchiectasis on HRCT. Review of older abdominal plane films shows calcification across the central upper abdomen at the T12/L1 level. What is the likely diagnosis? A. Cystic fibrosis, Cf. B. Sarcoidosis C. William Campbell syndrome D. ABPAE, Carter-Jenner syndrome. Chapter 10 Test Paper 5. Answers. 1a. Cystic fibrosis, Cf. The classic diagnostic triad in patients with cystic fibrosis includes an abnormal sweat chloride test result and manifestations of pulmonary and pancreatic disease. Upper lobe predominance is seen in many but not all cases. A diffuse distribution is also common. Normal to increased lung volumes are typical in CF and indicate air trapping and small airways disease. CT images show extensive cystic and cylindrical bronchiectasis and bronchial wall and peribronchial interstitial thickening. Findings are typically more extensive in patients with bronchiectasis due to cystic fibrosis than in patients with bronchiectasis due to other causes. Nodular opacities throughout the lungs correlate with areas of mucoid bronchial or bronchiolar impaction. Tree and bud nodules indicate the diffuse bronchiolitis that typically occurs in cystic fibrosis. In addition, a mosaic pattern of attenuation secondary to air trapping due to obstructed bronchi and bronchioles is commonly seen. Milleron B. ETAL bronchiectasis, mechanisms and imaging clues of associated common and uncommon diseases. Radiographics. 2015, 35, 410-1130. 2b. They are rich in glycogen. Serous cyst adenomas are benign cystic neoplasms of the pancreas that occur frequently in older women, median age 65 years. Serous cyst adenomas. 2. A 53-year-old woman with upper abdominal discomfort was sent for an abdominal US, which showed a hypoechoic mass in the pancreas. A CT was performed, which reported a possible serous cyst adenoma. Which one of the following statements regarding serous cyst adenomas of the pancreas is true? A. They are rich in mucin. B. They are rich in glycogen. C. They have malignant potential. D. They appear only as a unilocular cyst on CT. E. They are more common in men than in women. 3. Cyst adenomas are composed of numerous small cysts that are conjoined in a honeycomb-like formation. The size of these cysts ranges from 0.1 to 2.0 centimeters, but typically is less than 1 centimeter. The cysts are lined by glycogen-rich epithelium and separated by fibrous septa that radiate from a central scar, which may be calcified. This formation has led to the use of the more descriptive term microcystic pancreatic lesion. Serous cyst adenomas are usually discovered incidentally at imaging. However, those that are large may cause symptoms such as abdominal pain or, more rarely, jaundice. Progressive enlargement of serous cyst adenomas, especially those with a size of 4 centimeters or more at initial manifestation, may be seen at serial follow-up imaging examinations performed over a period of months or years. Multiple serous cyst adenomas may occur in von Hippel-Lindau disease. At MR imaging, a serous cyst adenoma appears as a cluster of small cysts within the pancreas, with no visible communication between the cysts and the pancreatic duct. The cysts show signal intensity of simple fluid on T2, weighted images, and the thin fibrous septa between them enhance on delayed contrast enhanced Mr. images. Cal B. ETAL MR imaging of cystic lesions of the pancreas. Radiographics. 2009, 29:. A 2-year-old boy with proptoses and CATS I was investigated with CT for persistent headache. Axial images showed a densely calcified mass replacing the right eyeball. The optic nerve was also calcified and surrounded by tumor, which had replaced most of the periorbital fat. The optic canal was expanded with extension of the mass in the middle cranial fossa. What is the diagnosis? A. Malignant melanoma of the choroid. B. Rhabdomyosarcoma. C. Coates disease. D. Neuroblastoma metastasis. E. Retinoblastoma. 4. A 29-year-old woman with 3 previous miscarriages, not explained. (1749-65). 3. Retinoblastoma is the most common tumor of the globe in children. It is seen in children less than 3 years, presenting with leukocoria. 75% are unilateral and unifocal, 25% are bilateral or unilateral multifocal. When seen bilaterally in conjunction with pineoblastoma, it is called trilateral retinoblastoma. 267. CT is preferred and shows clumped or punctate calcification, 95%, in the posterior aspect of the eye, extending into the vitreous humor with minimal enhancement. Absence of calcification makes retinoblastoma unlikely. On MRI, retinoblastomas are hyperintense on T1, weighted and hypointense on T2, weighted images, possibly due to calcification or paramagnetic tumor protein. MRI is better at depicting tumor extension along optic nerves and intracranially. CT is better at showing bone destruction, including expansion of the optic canal. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1396-7. 4a. 2 separate uterine cavities. Explained by any hormonal, biochemical or metabolic abnormality, was being investigated for a structural cause to explain the recurrent miscarriage. A pelvic MRI was scheduled, as it was the most definitive investigation for congenital structural anomalies and / or uterine masses. Which one of the following descriptions would suggest the diagnosis of uterus? Uterus didelphys. A. 2 separate uterine cavities with 2 cervices and 2 proximal vagina. B. 2 separate uterine cavities with 2 cervices. 243. C. 2 separate uterine horns with common uterine cavity, with 1 cervix. D. External indentation of the uterine fundus with 1 uterine cavity. E. Single uterine horn connected to a single fallopian tube. 5. With regard to stress fractures of Cavities with 2 cervices and 2 proximal vagina uterus didelphys results from complete failure of Müllerian duct fusion. Each duct develops fully with duplication of the uterine horns, cervix and proximal vagina. A fundal cleft greater than 1 cm has been reported to be 100% sensitive and specific in differentiation of fusion anomalies, didelphys, and bicornuate, from reabsorption anomalies, septate and arcuate. Bicornuate uterus involves duplication of uterus with possible duplication of cervix, bicornuate unicalis, or bicornuate bicalis. Bear SC, ETAL imaging of Müllerian duct anomalies. Radiographics. 2012, 32, 6E2 3350. 5b. Fibular stress fractures affect the proximal end. The tibia is the most commonly involved bone, accounting for up to almost half of stress fractures reported. Affecting the lower limb in athletes, all of the following statements are correct, except A. Anterior tibial stress fractures have a higher propensity of non-union. B. Fibular stress fractures affect the proximal end. C. Femoral stress fractures can affect the neck or shaft. D. Female athlete triad is associated with femoral and sacral fractures. E. Tibial stress fracture can be transverse or longitudinal. 6. A 3-year-old girl is referred to an endocrine clinic with unilateral jaw swelling noted at the dentist. Her general practitioner has also reported that she has signs of precocious puberty. An X-ray of the facial bones demonstrates expansion of the frontal bone and right side of the mandible. She is likely to have which other associated condition? A. Neurofibromatosis. B. Madelung deformity. C. Lisch nodule. D. Hyperthyroidism. E. Hypothyroidism. Reported in some series. 2 types of tibial stress fractures have been described: transverse and longitudinal. Transverse fractures are more common and can occur on the compression side, posterior, or tension side, anterior. Posterior transverse fractures of the tibial shaft are most commonly seen in long-distance runners. Tension stress transverse fractures of the anterior tibial shaft occur more commonly in jumpers and have a higher propensity for non-union and progression to an acute complete fracture. The most common site of fibular stress fracture in runners is the lower fibula, just proximal to the tibiotalar syndesmosis. Femoral neck stress fractures are associated with the classic female athlete triad of amenorrhea, osteoporosis, and eating disorders. Femoral neck stress fractures are often classified as tension side, superlateral or transverse, or compression side, infralateral, with the contention that tension side fractures are associated with poor prognosis and are potentially unstable. The femoral shaft is particularly susceptible to repetitive stresses on the medial compression side of the femur at the junction of the proximal and middle thirds. Fractures of the sacrum have predominantly been described in long-distance runners, particularly women, but have also been reported in hockey players. Sacral stress fractures are also associated with the female athlete triad. Lying SY, Whitehouse RW. Lower extremity and pelvic stress fractures in athletes. BRJ Radial. 2012, 85, 1016, 1148, 56. 56. 6d. Hyperthyroidism. The child has McCune-Albright syndrome, MOS, which is defined as the association of polyostautic fibrous dysplasia, PFD, precocious puberty, café au lait spots, and other endocrinopathies caused by the hyperactivity of various endocrine glands. Among the endocrine syndromes described in association with MOS are 1. Hyperthyroidism, 2. Acromegaly, 3. Gonadotrophonomas, 4. Hyperprolactinemia, 5. Cushing syndrome, 6. Hyperparathyroidism, 7. Gynecomastia, and 8. Hypophosphatemic rickets. Lisch nodules are associated with neurofibromatosis. Fibrous dysplasia in MOS can involve any bone, but most commonly affects the long bones, ribs, skull, and facial bones. There is no association between Madelung deformity and MOS. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:82. Chapter 10. Test Paper 5, Answers. 268. 7e. Cardigener syndrome. 7. A 35-year-old man known to the end for sinonasal disease presents to the chest clinic with productive cough. The house officer examining the patient struggled to hear the heart sounds properly. HRCT, among other findings, shows left lower lobe bronchiectasis without any central endobronchial mass to explain the focal bronchiectasis. What is the likely diagnosis? A. Cystic fibrosis, Cf. B. Sarcoidosis. C. William Campbell syndrome. D. Allergic bronchopulmonary aspergillosis, ABPA. E. Cardigener syndrome. Cardiogenital syndrome refers to the clinical combination of situs inversus, chronic sinusitis, and bronchiectasis in a subset of patients with ciliary dyskinesia. Patients with primary ciliary dyskinesia typically have varicoid bronchiectasis preferentially, affecting the lower lungs, particularly the right middle lobe and lingula, with chronic volume loss and consolidation. Tree and bud nodules related to infection and mucus plugging secondary to impaired clearance are also frequently seen. The associated finding of dextrocardia can be seen at chest radiography in cases of cardiogenital syndrome. Milleron B. ETAL bronchiectasis, mechanisms and imaging clues of associated common and uncommon diseases. Radiographics. 2015, 35, 410 1130. 8. Syndrome. 8. A 56-year-old 56-year-old man with gallstone pancreatitis is referred for a CT of the abdomen. The CT shows multiple cysts around the tail of the pancreas with further cysts in the lesser sac and left parcolic gutter. These are reported as pseudocysts. Which one of the following statements regarding pancreatic pseudocysts is false? A. They usually take for 6 weeks to mature. B. They can be multiple. C. They have an epithelial lining. D. They may communicate with the pancreatic ductal system. E. They may be extrapancreatic in location. C. They have an epithelial lining. Overall, pseudocysts are the most common cystic lesions of the pancreas. These lesions occur in the setting of pancreatitis, resulting from hemorrhagic fat necrosis and encapsulation of pancreatic secretions by granulation tissue and a fibrous capsule. The MR imaging appearance of pseudocysts may evolve over time. They are often irregularly marginate early in their formation but become well circumscribed, with a thickened enhancing wall, over a period of several weeks. Blood products and necrotic or proteinaceous debris are commonly present and produce intrinsically increased T1 signal intensity. The thickened and enhancing cyst wall seen on images corresponds to a thick rim of granulation tissue and fibrosis that is uniformly seen at histologic analysis. Other changes of acute or chronic pancreatitis are frequently seen in association with pseudocysts, and MR imaging may be the imaging modality of choice for depicting the features of parenchymal pancreatic disease. MR imaging has proved superior to CT for demonstrating internal complexity in pseudocysts. Furthermore, the signal intensity increase in tissue surrounding a complicated pseudocyst on T2 weighted fat-suppressed images correlates with the degree of inflammation present. However, in patients with a pseudocyst, the cause of inflammation is more likely to be chemical irritation than infection, and it may be impossible to differentiate between an infectious process and other possible causes on the basis of imaging features alone. Clinical manifestations may be similarly unhelpful, since the symptoms of chemical irritation may be identical to those of sepsis. Moreover, pancreatic pseudocysts may dissect along abdominopelvic facial planes to sites remote from the pancreas, e.g., liver, pleura, or mediastinum. Fistulation. 9. A woman who was 20 weeks pregnant was referred to the U.S. department by her midwife for a routine anomaly scan. The scan was reported as showing features consistent with congenital diaphragmatic hernia. All of the following are prenatal U.S. findings suggestive of a Diaphragmatic hernia, except A. Failure to visualize the stomach in the left upper quadrant. B. Cardiac dextroposition. C. Echogenic mass in the left hemithorax. D. Compressed left lung. E. Increased abdominal circumference. Chapter 9. Test paper 5. Fistulation may occur between a pseudocyst and one or more vascular structures. Cal B. ETAL MR imaging of cystic lesions of the pancreas. Radiographics. 2009, 29:17:49:65. 9. Increased abdominal circumference. The hallmarks of the diagnosis, in the first trimester as well as later in pregnancy, are the presence of the stomach, bowel or liver in the chest, shift of the mediastinum, and displacement of the heart to the contralateral side. Increase in abdominal circumference is not a feature. The contrary can however be observed and can be a clue. In 50% of affected fetuses, there are associated chromosomal abnormalities or other malformation. The hernia results from abnormal formation or fusion of the pleuroperitoneal membranes with the septum transversum, and it is surgically correctable. Neonatal death results from pulmonary hypoplasia and pulmonary hypertension. Daskalakis G. ETAL. First trimester. A 52-year-old woman presents to the orthopedic outpatient clinic with a painful forefoot. On examination, there was a painful response elicited by Mulder's maneuver. Which one of the following statements concerning Morton neuromas in the forefoot is false? A. They are often seen in young and middle-aged women. B. The interspace between the third and fourth toes is the most commonly affected site. C. The characteristic Mr. finding is a nodule with low signal intensity on T1W images. D. Ultrasound is a sensitive modality in identifying the lesion. E. Gradient echo Mr. sequences elicit blooming artifact in the lesion. 11. A 50 trimester ultrasound diagnosis of congenital diaphragmatic hernia. J. Obstet Gynecol RES 2007, 33, 6872. 10. Gradient echo Mr. sequences elicit blooming artifact in the lesion. Morton neuromas are masses composed of interdigital perineural fibrosis and nerve degeneration. Morton neuroma occurs between the metatarsal heads, most commonly between the third and fourth toes. Morton neuroma is more common in women, and high-heeled shoes have. Chapter 10. Test paper 5, answers. 269. Been implicated as a causative factor. Pain at the metatarsal head, often radiating to the toes, is characteristic. The MRI appearance is that of a teardrop-shaped soft tissue mass between the metatarsal heads, projecting inferiorly into the plantar subcutaneous fat, and located plantar to the intermetatarsal ligament. The mass is typically intermediate in signal intensity on T1 weighted images. It is ISO, or hypointense relative to fat on T2 weighted images, resulting in poor lesion conspicuity. The use of gadopentate dimblemin is helpful because intense enhancement typically occurs on fat-suppressed T1 weighted images, increasing the conspicuity of the lesion. Ashman CJ, ETAL forefoot pain involving the metatarsal region, differential diagnosis with MR imaging. Radiographics. 2000. 54-year-old man with suspicious findings on US was recommended for an MRI of the orbits for further evaluation. Sagittal Mr. images of the globe showed a focal area of thickening in the posterior aspect of the globe with hyperintense signal on T1W sequence and strongly hypointense signal on T2W sequence. What is the diagnosis? A. Malignant melanoma of the choroid. B. Rhabdomyosarcoma. C. Coates disease. D. Neuroblastoma metastasis. E. Retinoblastoma. 2001, 21, 614 2540. Stadnik me. Morton neuroma. MRI Web Clinic January 2006. 11a. Malignant melanoma of the choroid. Primary orbital melanoma is the most common primary intraocular malignancy in adults. MR imaging is superior to CT in the evaluation of choroidal melanomas, as melanin has intrinsic T1 and T2 shortening effects, thereby manifesting with increased T1 signal intensity and decreased T2 signal intensity. CT is nonspecific, often demonstrating a hyperattenuating choroidal mass. MR imaging is also valuable for identifying other features, such as large tumor size, extraocular extension and ciliary body infiltration, all of which also portend a poor prognosis. In addition, MR imaging is superior to CT for identifying retinal detachment and extrascleral spread. Notably, approximately 20% of melanomas are amyloidic, thereby lacking characteristic T1 and T2 shortening effects on Mr images. In addition, Mr signal characteristics may not always allow melanoma to be reliably distinguished from ocular metastases. Taylor TD, ETAL orbital neoplasms in adults, clinical, radiologic, and pathologic review. Radiographics. 2013, 33, 617 39 58. 12e, round pneumonia. 12, a previously healthy 9-month-old is admitted with tachypnoea and fever. His white cell count and neutrophils are elevated. His temperature is 39.2 degrees Celsius. An APCXR demonstrates a well-defined 5 cm rounded lung opacity with well-formed borders. What is the most likely diagnosis? A. Bronchogenic cyst. B. Pulmonary metastases. C. Neuroblastoma. D. Congenital cystic adenomatoid malformation. E. Round pneumonia. Pneumonia usually occurs in children under the age of 8 years. It is most commonly seen with bacterial pneumonia, pneumococcus. The mass has an alarming appearance on CXR, however, further investigation is only warranted if there is concern regarding the diagnosis. A CXR as soon as 48 hours later often shows dissipation of the mass into more typical consolidation, or complete resolution following antibiotic treatment. It is most common in the superior segment of the lower lobes. It is important to make the diagnosis to avoid unnecessary CT. Bronchogenic cyst is often an incidental finding, and often has a compressive effect unlike round pneumonia. Thoracic neuroblastoma may be an incidental finding, but the clinical history given is more in keeping with an infective process. Congenital cystic adenomatoid malformation, CCAM, is usually diagnosed antenatally or in the neonatal period. Indeed, in the newborn, 80% of cases of CCAM present with some degree of respiratory distress secondary to mass effect and pulmonary compression or hypoplasia. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:420. 13. B. Cavitating nodules amyloidosis refer. 13. A 77-year-old man with chronic inflammatory disease and renal failure is known to have secondary amyloidosis. All of the following are features of amyloid involvement of the respiratory system, except A. Interstitial septal thickening, B. Cavitating nodule, C. Focal amyloidoma, D. Calcification of central airways, E. Calcification and peripheral consolidation. 14. Refers to a group of disorders characterized by the deposition of abnormal protein material in extracellular tissue. Tracheobronchial amyloidosis generally presents with symptoms of airway obstruction. Classic radiological signs include nodular and irregular narrowing of the tracheal lumen, airway wall thickening, and calcified amyloid deposits. Lobar or segmental collapse may be seen. Pulmonary involvement by amyloid may be localized or diffuse. Radiologically, the diffuse parenchymal and alveolar septal forms of amyloid deposits appear as nonspecific diffuse interstitial or alveolar opacities. HRCT reveals interlobular septal thickening with a predominant basilar and peripheral distribution, small well-defined nodules, 2 for mm, and confluent. Chapter 10. Test paper 5, answers. 270. Consolidations located predominantly in the subpleural regions. Some nodules may show calcifications. Nodular amyloid deposits appear in multiple sites. Focal deposits are less common. Amyloid nodules are generally in the lower lobes and peripheral and subpleural areas. They are sharply defined with lobulated contours, contain calcification, in about 50%, are of multiple shapes and sizes and grow slowly with no regression. Cavitation is very rare. Vieira IG, ETAL pulmonary amyloidosis with calcified nodules and masses, a 6-year computed tomography follow-up, a case report. Cases 14, and US of the abdomen in a 43-year-old woman with a known underlying chronic condition demonstrates small cysts in the pancreas. She is sent for a dual-phase CT for further characterization. The scan shows multiple true cysts with no obvious suspicious features. Which one of the following conditions is associated with true pancreatic cysts? A. Tuberous sclerosis, B. Von Hippel-Lindau disease, C. Neurofibromatosis type 1D, autosomal recessive polycystic kidney disease, E. Multiple neuroendocrine. Cases J. 2009, 2:6540. 14. B. Von Hippel-Lindau disease. Pancreatic involvement in VHL disease includes simple pancreatic cysts, 50%, 91%, serous microcystic adenomas, 12%, and rarely adenocarcinomas. Pancreatic neuroendocrine tumors, 5%, 17%, also occur. Combined lesions occur, but neuroendocrine tumors and cystic lesions only rarely exist together. The reported prevalence of pancreatic involvement in VHL disease varies from 0% in some family groups to 77% in others. Pancreatic cysts are extremely rare in the general population, therefore, the presence of a single cyst in an individual undergoing VHL disease screening because of a family history makes it highly likely that the person has VHL disease. In general, cystic pancreatic lesions in VHL disease are asymptomatic or associated with only mild symptoms. As a result, they are typically detected during screening examinations and may therefore facilitate the identification of gene carriers. In addition, pancreatic lesions may be the only abdominal manifestation and may precede any other manifestation by several years, thus, recognition permits earlier diagnosis of VHL disease. Lung Rs, ETAL imaging features of von Hippel-Lindau disease. Radiographics. 2008, 28:6579. 15. C. Fetal Fetal MRI ultrasound imaging is the screening modality of choice for initial evaluation of the fetal central nervous system. However, using MRI additional abnormalities were identified in 50% of the fetuses. Measurement of the hydrocephalus should be in the true axial plane at the atria of the lateral ventricle and glomus of the choroid plexus. The ventricle is measured from the inner margin of the medial ventricular wall to the inner margin of the lateral wall. Ventriculomegaly can be divided into 3 subgroups: borderline, 10-12 mm, mild, 12-15 mm, and severe, greater than 15 mm. Morris J.E., ETAL. The value of in utero magnetic resonance imaging in ultrasound diagnosed fetal isolated cerebral ventriculomegaly. Clin Radiol. 2007, 62-144. 16. C. Generalized increased bone density hemochromatosis. C. Fetal MRI. D. Check maternal estradiol levels. E. It is a normal finding. 16. Which of the following is not a recognized radiographic finding in a patient with hemochromatosis? A. Chondrocalcinosis. B. Arthropathy with iron deposition in the synovium. C. Generalized increased bone density. D. Joint space narrowing. E. Osteophyte formation. Hemochromatosis may either be primary or secondary. It is most commonly primary and congenital with an autosomal recessive AR inheritance. It is relatively common in Caucasian populations with an incidence of 1 in 300 to 1 in 400. Men are affected about 10 times more commonly than women and at an earlier age. It is often characterized radiographically by beak-like osteophytes projecting from the second and third metacarpal heads. The other hallmark radiographic findings of hemochromatosis include the following: generalized osteoporosis, not increased bone density, arthropathy with iron deposition in the synovium, 50%, joint space narrowing and enlargement of metacarpal heads. Chondrocalcinosis is also relatively common in this condition, most often affecting the knees and triangular fiber cartilage. Dannert W., Radiology Review. Formation. 17. A 9-year-old girl with a long history of cough, wheeze, sinusitis, headache, and weight loss presented to the GP with an acute history of increasing breathlessness. Sweat test analysis shows 80 mol/L of sodium chloride in forearm sweat, normal 40 mol/L. All of the following are typical features on a chest X-ray, except A. Hyperinflation B. Bronchial dilatation C. Cystic areas in the lung D. Linear interstitial opacities E. Dextrocardia. 18. A 55-year-old woman with asymmetrical bilateral proptoses is referred for an orbital MRI to exclude retroorbital mass lesions. Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams & Wilkins, 2011:105. 17. Dextrocardia cystic fibrosis is an AR disorder leading to a defect in the CF transmembrane receptor, CFTR, protein resulting in defective ion transport in exocrine glands. Chapter 10. Test paper 5, answers. 271. In CF, abnormal function of sweat glands result in higher concentrations of sodium chloride in the sweat. Greater than 40 mol/L is suspicious and greater than 60 mol/L is diagnostic of CF. Spirometry shows an obstructive pattern with reduced FVC and increased lung volumes. Chest X-ray shows hyperinflation, bronchial dilatation, bronchiectasis, and its associated signs, cystic spaces, increases interstitial and linear/reticular opacities, and increased AP dimension on lateral chest X-ray. CF is not routinely associated with dextrocardia. Dextrocardia is a component of Cardigan syndrome, immotile cilia syndrome, which is associated with bronchiectasis and sinusitis, but not with an abnormal sweat test. Lesions. MRI reveals diffuse swelling of all extraocular muscles, with the swelling primarily involving the belly of the muscle without involvement of the tendinous insertions. The muscles are isointense to normal in signal on T1W images and hypointense on T2W images. What is the diagnosis? A. Orbital pseudotumor B. Thyroid ophthalmopathy C. Lymphoma orbit D. Steroid therapy E. Obesity. Test. Tasker RC, ETAL Oxford Handbook of Pediatrics. Oxford University Press, 2008:282. 18. B. Thyroid ophthalmopathy. Graves' ophthalmopathy is the most common cause of exophthalmos in adults. In Graves' ophthalmopathy, classically spindle-shaped enlargement of the extraocular muscles is observed, with sparing of the tendinous insertion. The inferior, medial, superior, and lateral rectus muscles, listed in order of decreasing frequency of involvement, may be involved. These findings are usually bilateral and symmetric, however, they may also be unilateral. Idiopathic orbital inflammatory syndrome, also known as orbital pseudotumor, is the second most common cause of exophthalmos. It is a non-granulomatous orbital inflammatory process with no known local or systemic cause. In idiopathic orbital inflammatory syndrome, unlike Graves' ophthalmopathy, there is tendinous involvement of the extraocular muscles. (19) A 62-year-old man with progressive cough and shortness of breath has bilateral patchy ground glass change with areas of dependent and non-dependent septal thickening in the basal lung zones on HRCT. Which of the following is incorrect about drug-induced lung disease? A. Diffuse alveolar damage occurs with gold. B. Chronic nitrofurantoin toxicity results in high-density consolidation. C. High-density liver is seen in amiodarone toxicity. D. There is no correlation between dose of methotrexate and toxicity. E. NSIP is generally the most common change on HRCT. LE Beatty CA, SUC-IO, non-traumatic orbital conditions, diagnosis with CT and MR imaging in the emergent setting. Radiographics. 2008, 28, 617 41 53. 19. B. Chronic nitrofurantoin toxicity results in high-density consolidation. Nitrofurantoin is used to treat urinary tract infections. Acute pulmonary toxicity manifests radiologically with diffuse bilateral, predominantly basal heterogeneous opacities. Nonspecific interstitial pneumonia, NSIP, is the most common histopathologic manifestation of chronic toxicity. Methotrexate-induced pulmonary drug toxicity occurs in 5%-10% of patients. There is no correlation between the development of drug toxicity and the duration of therapy or total cumulative dose. NSIP is the most common manifestation. Hypersensitivity pneumonitis and cryptogenic organizing pneumonia, COP, are less common. Diffuse alveolar damage and NSIP are the most common manifestations of gold-induced lung disease, with COP being less common. NSIP is the most common manifestation of amiodarone-induced lung disease. Pleural effusion is recognized. COP is less common and occurs in association with NSIP. A distinctive feature of amiodarone toxicity is focal, homogeneous, peripheral, high attenuation pulmonary opacities due to incorporation of amiodarone into type 2 pneumocytes. The combination of high attenuation abnormalities within the lung, liver or spleen is characteristic of amiodarone toxicity. Rossi SE, ET, HRCT. 20. A 50-year-old man is sent for an urgent contrast CT of the abdomen following a history of abdominal pain. The CT is unremarkable apart from inflammatory stranding in the omentum. All of the following are clinical features of omental infarction, except A. Occurrence in patients of all ages. B. Massive rectal bleeding. C. Slightly higher incidence in men. D. Acute right-sided abdominal pain. E. Rarely, a palpable ETAL pulmonary drug toxicity, radiologic and pathologic manifestations. Radiographics. 2000, 20, 5, 12, 45, 59. 20. B. Massive rectal bleeding. Primary omental infarction is often a hemorrhagic infarction resulting from vascular compromise related to the tenuous blood supply to the right edge of the omentum or to kinking of veins, usually those on the right side, deep within the anterior pelvis and the inferior extent of the omentum. Some omental infarcts are related to a combination of the reduced arterial and venous blood flow that occurs in hypercoagulable states, congestive heart failure, and vasculitis. Secondary omental infarction may occur after a traumatic injury as a result of surgical trauma or inflammation of the omentum. Often, the site of secondary infarction is near the surgical site rather than in the right lower quadrant, the typical location of primary omental infarction. Chapter 10. Test Paper 5, Answers. 272. Patients with omental infarction usually present with subacute onset of pain in the right lower quadrant, often with a slightly elevated white blood cell count. Other gastrointestinal symptoms such as vomiting, nausea, and fever are absent. Establishing a preoperative diagnosis of omental infarction is difficult because it often mimics acute appendicitis or cholecystitis. In most cases, the radiologist makes the diagnosis after cross-sectional imaging has been performed. Omental infarction demonstrates a variety of imaging appearances at CT. Classically, it appears as a fatty, large, greater than 5 cm, encapsulated mass, with soft tissue stranding adjacent to the ascending colon. Early or mild infarction may manifest as mild haziness in the fat anterior to the colon. COM-AL imaging manifestations of abdominal fat necrosis and its